Welcome, everybody, to the Maine Rural Healthcare Education Grand Rounds, the first one for 2025. It is great to have everybody here as everyone starts coming on in. I'm thrilled to announce our presenter today. It's Dr. Kalli Varaklis. Dr. Varaklis currently serves as DIO for all of Maine Health. She oversees graduate medical education for more than 30 residency and fellowship programs. In addition to her work with Maine Health as the DIO, she also serves as the principal investigator for the MERGE Collaborative, which is a statewide effort across all ACGME sponsoring institutions to create more learning opportunities for Maine's rural spaces. And so, folks, I'll invite you to turn your cameras off for the presentation. Kalli will give her a quick presentation, and then when it's done, she will go into a Q&A session. I'll encourage everyone to turn those cameras back on. And Kalli, the floor is yours.
Thank you. Thanks for joining. The title today is AI-supported precision medical education. And thank you for having me. We do offer continuing education credits, and I'm just going to take one moment to allow folks, if you text 96271 to this number or Cloud CME, you will receive a text. So that we're clear, I have no relevant or irrelevant relationships with any ineligible entities, and I do own the content of this lecture with two caveats. Thanks to the Chief Academic Officer of the American Medical Association, Dr. Sanjay Desai, for sharing some of his slides, and thanks to Dr. Ross Hilliard, the Maine Medical Center Internal Medicine Residency Program, for sharing some information as well. And then this is the information related to the Joint Accredited Provider for Interprofessional Continuing Education. And I will put this up at the very end as well. So the objectives of this talk are very simple. What is the problem in medical education that AI can help solve? Why do we need AI, if at all? Appreciate how augmented intelligence is actually being used currently, and explore really what the future is of artificial or augmented intelligence for GME education or nursing education or PA education in the future. What I am not talking about today is the use of ChatGPT type technology for patient communication to support note-taking. I'm not talking about personalized medicine, predictive clinical analytics. I'm not talking about a primary care AI app on your phone for self-assessment and triage. And I'm not talking about the exam room of the future, although it's incredibly interesting. And I'm not going to talk, although we can talk about it in the Q&A if we want to, the risk of over-reliance on artificial augmented intelligence with the new generation of providers who may or may not be developing reduced clinical thinking and judgment. I think that's a concern about artificial intelligence. So how is AI currently being utilized in medical education? In a ton of ways. Tons of personalized learning, and not only in medical education, but in education, elementary school, middle school, college, high school. And there are clear AI algorithms that help tailor educational content to individual personal styles and needs. So you do a quick assessment, and then AI can curate personalized learning. This allows for adaptive learning, which is actually taking individual data to personalize learning experiences based on individual performance and proficiency. And so that could help folks who are struggling with content, but it could help folks who really are able to get this content quickly and offer accelerated experiences. This may bridge the equity gap in education, which is difficult for teachers in traditional classrooms to be able to have time to do. It can provide technology to assist with disabilities. So speech to text, for example, technology has been very helpful for those who suffer with dyslexia. And it can provide a lot of data to support the development of high quality individual learning plans for everybody. AI tutors are virtual tutors that actually help students review material, understand complex concepts outside, and really help with the homework part of it in addition to the classroom instruction. And Microsoft, Bill Gates has a goal that every student in America will have a personal tutor available on their classroom issued computer in the next several years. There are AI programs to mentor and coach, to inspire, for example, during writing prompts. And let's face it, artificial intelligence facilitates multimodal learning. It's easy to pull video, photographs, text to enhance learning, things that can be done much faster with artificial intelligence than perhaps we have time. And then data. Obviously, this is the key thing that artificial intelligence is able to access. So it can confirm data, when I use the word confirm, because we'll talk about the risks, but it also can access data in an extremely fast time and has almost immediate access to all data. AI is currently being used for assessment tools. It can make assessments way more efficient, data-driven, can create and grade examinations, and may actually write better questions than many educators. It can analyze answers for trends and can analyze evaluations for synthesis of a large amount of data. And so it can look at every single 11th grader in the United States and look at evaluative data and make really looking at for trends and perhaps areas of gaps. Can provide very detailed feedback to learners to help guide continuous learning. Simulation and virtual reality I'll get to in a little bit, but really artificial intelligence in simulation. We know simulation's a risk-free environment to practice on, not only to practice procedures, but to practice communication, decision-making. AI really takes that to another level, especially with the virtual reality. Simulated scenarios can be more cost-effective, more realistic training, very precise feedback, especially in procedure skills. It took 41 seconds for you to complete this discrete task, is one example of that. And really, if you have access to the technology, which is of course one of the biggest ifs, and you're going to hear this again and again in this talk, it really can reduce errors, it can increase efficiency, it can increase the slope of learning, enhance psychomotor skills, and individualize the training. And so instead of saying everybody needs to complete these 12 tasks, it will do sort of an ability to individualize training. So one learner might need to do task number 6 40 times before they go to task number 7, and that improves learning. There's some early data saying that there's a shorter introduction to competency curve for newer procedures, and of course our robotic friends in the industry have really been focusing on this as a benefit for robots. It's easy to ask the question, does a surgical residency in the future to start in the sim lab for the first 3 months before touching any patients? And my best guess is we'll get to there. Certainly, artificial intelligence or augmented intelligence is making an impact on recruitment. Certainly medical school, college, residency applications, we know people are using ChatGPT and similar tools to help write their personal statements and summaries. The question isn't, are they using it? That question, that ship has sailed. And there's some data to say that these type of technology actually help address some previous inequities in that students and applicants who had greater access to resources have always been able to hire coaches and mentors to write their personal statements or at least heavily edit them. And now ChatGPT is widely available to those who do not have those access, or for example, for whom English is not first language. Certainly in residency programs, our residency programs are using AI that use natural language processing to review resident application files. And this year, the AAMC just made Cortex free for all programs in recruitment year 25-26. And Cortex is an artificial intelligence or augmented intelligence program that actually looks at hundreds of applications specifically to help limit the number of applicants that will be considered for interview. So this is all being done now. So when we think about it, what's the problem we're trying to solve? How do we think about artificial intelligence in the future of graduate medical education? And yeah, we have to keep the end game in sight, which is what our patients need. And that's what we're the whole training for. And what our patients need are competent providers who are competent upon graduation and stay competent throughout the time that they are practicing medicine. And what is the problem in medical education that AI can help solve? The problem really is evaluation and feedback. So if we take 1 second and we think about competency development in medical education, it's kind of a simplistic slope. Start in pre-med, undergraduate, graduate medical education, and then continuing professional development. The same competency slope applies to our APP colleagues and nursing colleagues and pharmacy colleagues. But if you look at the data more carefully, the actual competency development is not a complete straight line. And there is variability, particularly around these areas of transition. So UME to GME and into practice. And these plateaus are specifically, again, around transition, but there are also definitely ups and downs. It's not a linear graph. And certainly, there are variable journeys that do not follow the major pathway. And so we really end up with a wide range of competency. Yes, most people are on this blue line, but there's a not insignificant number of folks. So this is at graduation, most folks are competent, but as they go into practice, that curve tends to fall down below competency. And so the question is, can artificial intelligence use data and outcome to individualize education so that we get rid of these lumps and bumps in development and smooth the pathway so that we really are producing competency and also reducing these plateaus from the continuing during these transitions? And so the idea would then be, can we end up with a competency curve that really looks like this for the vast majority of our graduates and practicing practitioners, again, to enable better patient care, which is the end product here. So the limitations, the problem, are evaluations. There's a significant gap between the education and patient outcomes. And so we can give a ton of feedback to a resident. Good job, you didn't say this, maybe you should sit down when you're giving bad news, maybe you should use your left hand to position this before you put the trocar in. We can give a lot of feedback, but the feedback isn't actually related to patient outcomes. Because you did this, this is what happened to the patient outcomes. And there are many reasons that happens, partly because residents practice supervised medicine. And so there are very few examples of where they're actually doing something that they have sole attribution in terms of the patient outcome. We have data linking GME education to patient outcomes after training, but not during training. So that's one big problem. And the other big problem are evaluation. Every program director struggles with this. The evaluations that we are used are limited by our end user, who are our faculty. Faculty are busy and they oftentimes don't have time or perceived time to complete evaluations. Completion rates are low. Program director inexperience, maybe having too long of evaluations, which is another barrier. The validity, the quality, there's a wide variability. And as DIO, I can see that in all of my different programs. We have some programs where faculty completion rate is really stellar and others where it's not. So really, can artificial intelligence help us with this, which is the crux of the problem? How do we get better feedback to our residents that is related to patient outcomes? Well, because our trainees, they need high quality feedback, but they need feedback that they believe, right? They need a lot of it, and they need to believe about the quality. And then once we have all this data, we have to have a coaching system that can really look and help learners evaluate all of this massive amounts of data. So what could this look like? Well, NYU Langone is really at the forefront of artificial intelligence. This is not widely available, but they got a humongous grant, and they trained artificial intelligence to read every single internal medicine inpatient clinical note and give feedback immediately to the resident on a personalized dashboard. And so it really just says this is a high quality note, thumbs up, or a low quality note, thumbs down. And here's an example of a low quality note. Here's an example of a high quality note. All of this information on every single clinical note that they write goes to the program director. And you can see here, program director cumulatively has 661 residents. And these are the number of admissions, the number of patients. So you're looking at big amounts of data. And the program director can see all sorts of things, the percentage of high quality notes based on the diagnosis category, what percentage of quality notes as they go through the training program. So there's a lot of data here that the program director can think about in terms of changing the program. So they might consult with their endocrinology diabetes faculty and say, you know what, less than 40% of the notes are actually high quality. We need, how should we fix this? Is it a didactic? Is it peer reviewed notes? How do we give them better data about this? The resident gets their individualized view. So the resident gets to see where they are compared to 660 other residents, right? And so this resident here is going to look at this data and say, oh, that actually means something, because there are 660 residents who are doing better than I am. Maybe there's a couple of that are doing worse. But I would argue that this is very, very believable data to this resident. And you can see here that this particular resident took this to heart and actually improved the quality of the notes that they were writing, as most people would do when they found out where they were. And they can also click on every single one of these notes to see why it was high quality or low quality. So AI can also facilitate individual experience, experiential education. And so again, at NYU, they have linked the EMR to education. So AI reviews every single patient seen by an internal medicine resident clinic or psychiatry resident, and then they synthesize individual references and resources and send them directly to the learner on their mobile device. Hey, you recently wrote a note on EPIC for a patient with a diagnosis of schizophrenia. Here are some educational resources you may find useful. So there's quick learning, there's basic science, osmosis, which is a clinical practice, and then they also include recent reviews, guidelines, or consensus articles, so that if they want to do a deeper dive, they can do that. Unbelievably, these educational resources are automatically updated when the new high quality literature is published and resent to residents. So the residents getting a lot of information on their phone, but they are decreasing the barrier for the resident to say, boy, is this, when I want to read, we know that reading about patients you've just seen cements the information. Here is where they decrease the barriers to finding it. There's another program that looks prospectively at patients who are scheduled for the next week and saying, hey, you're scheduled for this patient next week. Here are some resources you might want to look at. Not going to talk a ton about this, but AI will revolutionize surgical education. Interestingly, companies are all over this. They're making these huge assertions like the future of medical education. Traditional training is not up to the challenge of educating today's surgeons. So by our system for virtual surgical training. It's interesting, there is some data to support this, and we certainly know that virtual reality and simulation can help, as I mentioned, that curve from an introduction to a new surgical skill to competence. But these are pretty wide, broad statements. And really, the idea here is that they practice on virtual reality. They can pull out bones, they can drill. That we'll share the slides, but this is an interesting virtual immersive reality video. It's only 3 minutes that really shows the extent that can be done with this. Very few studies are actually looking. You can see this number was 18. This was published a few years ago, just in 2020, and they are increasing their numbers with similar results. But they looked at immersive virtual reality versus conventional training, and they pick up the task faster and they do it better. Concluded that it was 34 times more effective. I wouldn't quote that, but that was part of their. So lots of interesting questions that come up with virtual reality training. The platforms themselves are new. They're not peer vetted. They're supported by very few studies. Make no mistake that stakeholder profitability is a huge goal of this educational technology, and it's hard not to use it if it's available. We know that AI can perpetuate racial and gender biases and cannot integrate factors about racial background and socioeconomic status that are risk factors for surgical outcomes very easily. Super expensive, not available. So now we have haves and have-nots. Requires massive amounts of data, right? So privacy concerns, cybersecurity concerns, storage, ownership, climate impact. Biggest, one of the huge things about big data is the energy to fuel cooling of this. So inequities. So there's a lot of concerns about this. AI will revolutionize surgical training in the operating room as well, can create a procedure plan. Really, that's what residents and surgeons are supposed to do. Can tap into existing risk analysis algorithms that are easily accessible, suggesting ways to reduce threat, and actually can recommend a best strategy and best procedure. You can see some of the concerns about this. The AI can first assist and actually map out what they think is going to happen in the next 30 seconds, map out safe areas. They can also make a judgment about whether a resident should be doing this case at all, just hugely problematic. Unresolved issues, who is liable if something goes wrong? If you do what AI suggests, are you responsible as a surgeon or is AI? What happens if you don't do what AI suggests because you're a surgeon who's got clinical judgment? How do you develop clinical judgment if AI is telling you what to do all through your training and early practice? So how does a resident get to operate if AI is making recommendations against having a resident operate? Who's monitoring garbage in, garbage out? Again, population bias. What if you're not training with this expensive technology, and what are the ethics involved? I'm not going to talk about continuing professional development other to say that AI will almost certainly be incorporated into the re-credentialing process for faculty eventually, and this is going to be around procedures. When I think about the number of procedures that I was competent to do at the end of my training and the number that I was able to do at the end of my practice, the number was about the same, but there were two Venn diagrams with a pretty small overlap. We stopped doing the Birch procedure and we started doing robotics. And so I do think limiting practicing physicians' scope of practice based on competency is a good thing, but it's a difficult thing to talk about because it limits practice, which is appropriate. If you can't do a procedure or show that you're competent in a procedure, you shouldn't be doing it. But that has implications for your practice, for your personal reimbursement, and for access to patients, particularly in rural settings. So another topic for another day. So lots of power and future for artificial intelligence to support medical education, lots of privacy concerns. assessments lack. It's difficult to individualize graduate medical education. So, somebody may say, I just need to do procedures and I don't need to do all of this other stuff that I'm paid for. So it's complicated. Most programs do not have high quality coaches. It's expensive, therefore access is limited, population bias, and who is monitoring all of this is a big question. So that's what I had to say today about artificial intelligence in medical education.
Thank you, Kalli. I invite everyone to turn your cameras back on if you're able to. Some might not be able to. And I hope we have a good Q&A session.
Great.
I'll ask a question to the group. Are any of these tools being utilized, any AI tools in your organization, your practice? Is anything creeping into your daily workflow? Not yet? No one jumped to share the toys they have? Ashley.
Hi, everyone. Great presentation. I'm curious, after kind of looking at some of these models and examples in the literature, how are organizations, what are they doing around readiness to prepare faculty? And because I imagine the adoption curve is, everyone's, well across the spectrum on adoption for all of this. I don't know if you can comment on that or.
Yeah, I think that the bigger issue is availability. I think once it's available, you have your early adopters. The early adopters work with companies to become sort of trained to do it, and then it's a train the trainers model. So I think there's all sorts of ethics about who gets to do that. We certainly saw that in robotics with gynecology, right? Who got to be those early adopters, and then they owned robotics and sort of pressures from patients, robot versus other things. So it's tricky. There's some ethics that are tricky about that.
Yeah, Kalli, great presentation. And from the ethical side, have you heard from any of these programs that have been using AI to do their screening for their applications as to how that has gone for them?
Yeah, I mean, some of our programs here at Maine Medical Center are using Cortex. And Ross, are you using Cortex? So Ross can tell you, Ross can answer this question.
Yeah, no, so it's there in terms of, it's kind of overall with Cortex, it's mostly just natural language processing, and the fact that, most of that stuff comes over from Eris in a PDF form. They're getting better about sharing that data in true data form, but can do everything from, pulling out kind of overall grades. But really how I've used it is, identifying, extra things that would fall within our realm of things that we're particularly interested in out of, personal statements or things along those lines. It can find kind of keywords or things along those lines in the morass of stuff that we all have to read if you get involved in screening applicants. So that's been helpful. And they're building other tools that can also start to identify kind of trends, as well as helping to parse through the MSPs and actually give you some kind of idea of where people fell in their individual schools. I have hope that will also start to get better in the future, and being able to kind of compare people between within an individual school and help to do some of that comparison and simplify some of that for us as well. But they're certainly sitting on a lot of data. There's a reason that AAMC partnered with Valamis to do all of this. They're getting data on the back end too. So, and
to Ashley's point, who is training programs directors to do this, and who is monitoring this? Who knows if somebody is putting into Cortex the number one word that suggests somebody is affluent and Caucasian? If you know it, don't say it. The number one word is lacrosse. in a personal statement. So who is monitoring if program directors are just putting the word in lacrosse to actively search for that? And I'm sure that's not common, but there's nobody looking for that. So that's one of the questions about the ethics. Are you, you know, it's a definitely a tool for discrimination, potentially. Any other questions or comments? Thank you all for attending. We are going to post these videos. For those of you who are interested, I really do suggest you take a look at that virtual reality. It's very interesting, and there's one, 10 seconds where they're training orthopedic surgeons in a room. There's 100 of them, and 96 of them are white men. And so it's very interesting. It just highlights some of the concerns with artificial intelligence, at least at this time.
Yeah, that's my fear, is the haves and the have-nots.
Absolutely.
These things are expensive. Whether it's hardware or software, it's just incredibly expensive, and especially for smaller community-based programs who just have no money right now whatsoever. You look at the NYU Langone and go, oh my God, how do they afford to do this? And it's volume, volume.
You know what, Jim? On a separate conversation, let's see if we can leverage the Merge Collaborative to talk to the Rue Institute to do something for all residents in the state, as opposed to some of them through Merge. I bet you we could get them to do that.
Yeah, and I think and they're a great partner for us to think about that as they go through their entrepreneurial programs. I think that's a great idea. I know for us, our sim lab was built originally off of some grant funds, and thankfully we get some other funding to help continue it. But augmenting it is going to take it's going to take financing, and those are difficult. And then of course it's the what is the product really like? I mean, we've looked at several augmented reality training programs, and I'm like, yeah, they're great, but there was no tactile stimulation to it. And I continue to go, it's great for you to show me putting my hands where the baby comes out, but it has nothing to do with how much pressure I have to put in to pull the baby out. Having to do that last night at 10 o'clock. And so, those are the kind of things that I go, it's just not there yet, but there are certainly some that are getting there.
Let's see if we can pursue this. That would be a big win for
it would be.
Training across the state. Great idea.
That's wonderful. Well, thank you, everybody. Great having you here. Before we all exit, I always like to pitch what's coming next month. So our next Grand Round session is on February 14th. And being an emotional day that it is, we're going to be talking about emotional intelligence. Our presenter is, see a little tie in there. His name is Frank Bailey, and he is a medical educator at Eastern Maine Medical Center. And his presentation is called Stay Calm, Teach On, Managing Stress While Precepting. So I'm looking forward to it.
I just proofread his presentation. It is absolutely awesome. It is definitely worth the 45 minutes. He is going to do an excellent job at making us all feel better at what we do.
Wonderful. Well, we hope to see everybody. Bye, everybody.